So we start to actually then get down into this bottom line where most of the time we're kind of working away at this group. Let's actually talk about what a prepared, proactive practice team would look like, and what an informed, activated patient would look like, and then what are the infrastructures that we need to support those kinds of people. So what characterizes this kind of team? Well, certainly we want to maximize capacity and access and clearly improve health outcomes. We want to utilize that team around this patient population, and we want to optimize not just the episodes of urgent care that they need, but all of their needs. So the principles here are, first of all, to standardize and support that team. Align the team with the most responsible provider. That provides not only leadership, but also accountability. And there has been a lot of debate around that. Is that provider a family doc? Could it be a nurse practitioner? We personally have thought about that and actually tried a few different things, and I need to say that we've decided that it's a patient-physician dyad that seems to work for us. We've embedded the protocols and guidelines into what we do every day, so that if, for example, and I'll use the example of hypertension later, but if somebody comes into the office for a routine check of even a sprained ankle, and their blood pressure is a little high, and I say, I'd like you to see my nurse, I know exactly what my nurse is going to do. I don't have to guess, well, will she do it, or should I do it because she might not? I know, because we've embedded these protocols into the daily routine. And even if somebody comes in for something else, they might go to the nurse and have their blood pressure checked as well. So we use opportunistic ways of doing that. And then we've actually developed specific indicators that we can measure to say, are we doing any better? So a planned family practice team actually looks at the profile of your patients, identifies the target conditions, identifies the frequent flyers and the chronic pain patients, and then actually generates some of the pre-visit prompts and how we're going to respond. So if I look over my patient list and I know, uh-oh, here's Mrs. Smith again, let's have some planned approach to how we're going to manage that visit. So this is my hypertension example, and we debated over whether we should have everybody over 18 get a blood pressure every time. If they come in for a cold, we decided we were going to check their blood pressure. Because if you just say, well, we'll just do it at complete checkups, or we'll just do it if they're complaining of chest pain, you miss the majority. And we know that a third of people out there have high blood pressure and they don't even know it. So we bit the bullet and said, we're going to measure everybody's blood pressure every time. We've backed off a little from that. So if somebody comes in a week later because their cold isn't any better, we probably wouldn't measure their blood pressure again. But we felt it was important that we measure everybody. We screen them all. And if their blood pressure is over the target, I now have a mechanism to refer those patients to my nurse, and she follows those. We also look through our medical records to find the hypertensives that weren't in control, and we referred them on as well. So using the guidelines, and the guidelines are very clear, we're able to have then an established diagnosis by the nurse. She then goes on and does some risk stratification, so she knows exactly what the labs are that I'm going to order for that person with a diagnosis of high blood pressure. And by the time the patient comes back to me, they've already had their education around the non-pharmacological things that we could do. And so the next time I see that patient, instead of me doing 3 visits to make a diagnosis, they've now had a whole bunch of work already done. And now I review this and we start to talk about possibly some pharmacological interventions. And then I refer them back to the nurse for monitoring. And Are see them again if indeed they're not under control yet. Immediately my nurse comes to me and says, I've got so-and-so with high blood pressure in my office, and these are the readings. And we use this particular form, and this pathway is for high blood pressure not yet diagnosed, and we have a second pathway for high blood pressure not in control. And so she'll come and say, this is what we've done. What do you think? What's our next step? It's been very effective. It used to be, when I was doing it myself, a systolic pressure of 155, it's just about as good as I can get, and we got this person on 3 or 4 medications already. I guess we just have to accept 155. We don't have to accept that anymore. We've got people in target almost every time using all the guidelines, not just the pharmacological ones that I was using before. So I wanted to use this example of group visits around this particular issue. Do people use group visits? It's in the literature all over the place. There's all kinds of group visits for all sorts of things. And I was noticing that I was having this really high burden of care for complex elderly in my patients. And they were coming back and coming back. And I said, okay, let's try a group visit. And everybody said, oh, I don't know. We're not ready. Patients aren't ready. No, maybe we better talk about this some more. And no, we said, no, let's do it. So I looked through the records with these criteria. People greater than 65 with greater than 12 visits a year. And there was a list, and I went through the list, and I identified 14 patients. Average age was 78 and a half. Average number of diagnoses was about 5. Average visits in the last 12 months, 18. And I looked at how I was seeing these people, and I would be, if I could get away with a 15-minute appointment, I would be lucky with that type of patient. So I put one morning per month aside, 2 hours, usual caseload of 8. We drew in all 14 patients to that. My team of my medical office assistant would go around and update medications and find out if there's any concerns. My RN would lead an educational discussion around a topic of their choice, bringing in speakers. I'd see every patient, every visit, but I'd take them out of the room and see them for a few minutes. But all the work, their blood pressure and their medication list had all been updated already. We always had the pharmacist there, which was a great boon to that. It just was beautiful. And home care nursing started to come in November because they started to hear about this. So what's happened? We have reduced the visits from that 17.9 to 8 visits a year. They wouldn't miss. There is virtually perfect attendance. They're saying, this is so wonderful. And they want others, can we get our friends to come as well? It's a social event, and we have coffee and cookies, and it's really become quite an event. For me, crunching the numbers, I've created for myself 100 new appointments that I can now see other people for, and I'm creating better care, and my patients are really highly satisfied with this. So this group visit thing has been very good. We're starting another group visit around prenatal visits too. So the last thing is to ensure sustainability through measurement. And so we have a measurement team, and metrics really matter. And there's a drumbeat to change that comes around measuring. And so you think about a little change, you say, okay, well, let's try it this way. And then you can hardly wait to get the measures to see if it made any difference. Did it really help or not? And we actually have this whiteboard at our back door. It's the first thing you see when you walk in the door. And it's third to next available appointments. And I look at that and I say, uh-oh, 15 days, I better change the way I work today. And so it really influences my day-to-day work. So the measures become this drumbeat that we almost begin to expect and want to see. And there's some really good measurement tools that are available out there, and they're free on the net. These are our access measures, the delay, which I showed you, our demand and supply we measure. Continuity, what's the percentage of my patients' time that they get to see me? And it started at about 34%. So 34% of the time, my patients were able to see me. We now have it up to 87%. So 87% of the time, my patients are able to see me. We measure a number of screening efforts. We measure blood pressure, hemoglobin A1C, vaccinations, tobacco use, and how well we're doing with our guidelines, but also these screening techniques. So when we do that, this is actually comparing 3 clinics within our network. And we really emphasize that this is really measurement for improvement, and it's transparent. So there's one clinic here that's doing really well on all the breast, cervical, and colorectal screening. What are they doing? What's different? So we bring them up and say, okay, what are you doing here? Why are you doing better than the rest of us?